And now one outcome of GOG-99 and VORTEC-1 was in helping define patients who might be at a higher risk of recurrence than other intermediate risk patients. And so GOG-99 defined a number of risk factors, including grade 2 and 3, LVSI, and outer myometrial invasion combined with age to identify a high-risk group. In VORTEC-1, risk factors that were defined were age greater than 60, grade 3, and deep myometrial invasion. Now, what about the low intermediate risk patients that don't fit into that category? Well, I think in general, those patients can either be observed or you can consider vaginal brachytherapy for those patients. Now, as radiation oncologists, we're always interested in improving the therapeutic ratio, either shifting the black curve, which is the tumor control probability curve, to the left, or shifting the right curve, which is the normal tissue toxicity curve, to the right. And at least with vaginal brachytherapy to the upper vagina, we can significantly reduce the toxicity there with adjuvant brachytherapy in lieu of pelvic radiation. And so there have been a number of retrospective studies that have initially looked at this, demonstrating that with vaginal brachytherapy alone, that there were low rates of recurrence in the vagina as well as in the pelvis region, as well as low rates of long-term morbidity. And I think you can lower the rates of long-term morbidity, specifically vaginal stenosis or vaginal shortening, by either using vaginal dilators or decreasing the dose per fraction for patients. And so as a result, VORTEC-2 was initiated, which was a randomized study of pelvic radiation or vaginal cuff brachytherapy to determine whether or not these patients could just receive vaginal cuff brachytherapy, given that the majority of recurrences in intermediate risk patients occur in the upper vagina. Again, this study excluded the highest risk stage 1 patients, those patients with deeply invasive high-grade disease, and they did not necessarily do a systematic lymph node dissection again in this study. So the differences in vaginal recurrence rates in the study were not significant. They were equivalent in both arms. However, there was a significant difference in pelvic recurrences, 3.8% in the vaginal brachytherapy arm and 0.5% in the external beam arm. Although these were significant, I think most of us would think that 4% is pretty low. And as a result, these patients probably wouldn't benefit from pelvic radiation. And not surprisingly, the toxicities are quite higher with pelvic radiation than with vaginal cuff brachytherapy, in particular gastrointestinal and skin toxicities.